Hi everyone, my name is Adithi Ramasagaram, and today I'll be presenting my research on evaluating the diagnostic performance of bedside lung ultrasound, which is also known as POCUS, compared to the chest X-ray in detecting pediatric pneumonia in emergency settings. And this project was conducted under the mentorship of Dr. Mohammed Wasim and focuses on understanding how emerging imaging techniques can improve diagnostic speed, accuracy, and safety for children. So before diving into the details of my review, I just wanted to highlight a few key terms that frame this research. So first, pediatric pneumonia. This is the condition that I focused on specifically in children presenting to emergency departments. Next is POCUS, or a point of care ultrasound, which is a bedside imaging tool that's becoming increasingly popular as a potential alternative to chest x-rays. And the chest x-rays have traditionally been the gold standard, but my paper explores whether POCUS can match or even outperform them. I also focused on diagnostic accuracy, specifically sensitivity, which is how well a tool detects true pneumonia cases, and specificity, which is how well it rules out cases without pneumonia. And finally, since this research is directly tied to emergency medicine, it's important to understand how these tools can perform in high pressure, time sensitive settings. So, pneumonia remains one of the leading causes of illness and death in children worldwide, accounting for about 14% of deaths under age 5, according to the World Health Organization. And emergency departments, diagnosis is particularly challenging because symptoms like fever, tachypnea, and wheezing often overlap with conditions like bronchiolitis or asthma. And traditionally, clinicians have relied on chest x-rays, which allow us to visualize pulmonary consolidations and infiltrates. But x-rays have significant drawbacks. So for instance, they expose children to radiation, which carries cumulative risks. And interpretation of chest x-rays can also vary depending on the skill of the radiologist. And lastly, in many low-resource settings, imaging infrastructure isn't always accessible. So this raises quite an important question. So can POCUS, a faster, safer, and portable alternative, match or outperform X-rays for pediatric pneumonia diagnosis? And this question is the focus of my review. So POCUS, or a point of care ultrasound, is performed at the bedside in real time, as I talked about earlier. So unlike chest X-rays, there is no radiation exposure, which means that it is safer for children. It's also portable, which means that it can be used in any setting, including rural and emergency care. And lastly, it provides fast results, meaning that diagnosis can be made within minutes. Using ultrasound, we can visualize pneumonia indirectly by identifying pleural line abnormalities, consolidations, and B-lines, which are all artifacts that represent fluid accumulation in the lungs. However, a limitation is that POCUS is operator dependent, and its accuracy relies heavily on training and experience, which became an important consideration in my research. So the goal of this review was essentially to evaluate the diagnostic accuracy of POCUS compared to chest X-ray in pediatric emergency settings. Specifically, I analyzed studies measuring sensitivity, specificity, and lastly, the limitations of each method and their clinical applicability. So for my methods, I conducted a narrative review using PubMed and Google Scholar, searching terms like pediatric pneumonia, lung ultrasound, and POCUS versus chest X-ray sensitivity. To be included, studies had to evaluate patients that were from 0 to 18 years old, compare POCUS and chest X-ray for diagnosing pneumonia, report sensitivity and specificity, as well as include details on operator experience. So in total, I analyzed 14 studies, ranging from large meta-analyses to resource-limited case studies. So as for my results, across the 14 studies, POCUS consistently demonstrated high diagnostic accuracy. For example, the sensitivity ranged from 91 to 96%, and the specificity ranged from 90 to 95%. For comparison, chest X-ray had a slightly lower sensitivity, around 86 to 92%, but it had a slightly higher specificity, around 95 to 98%. So this essentially indicates that POCUS is better at catching pneumonia cases, but slightly more prone to false positives compared to chest X-rays. In particular, studies highlighted POCUS's strength in detecting peripheral consolidations, lesions that may or may not always be visible on standard chest X-rays. So this is a table from my paper that contains the sensitivity and specificity values of the studies that I was able to incorporate in my research. So a few of the notable studies was one by Bulk in 2018, which had a pooled sensitivity of 95.5% and a specificity of 96.3% for POCUS, which significantly outperformed chest X-rays, which had a sensitivity of only 86.8%. So, additionally, a study by Zhonghao Dong in 2023 analyzed 17 studies as a meta-analysis and confirmed around 94% sensitivity and 92% specificity for POCUS. And lastly, a study by Yogendra Amatia, also in 2023, showed that in a low resource setting, POCUS proved to be invaluable, showing 95.5% sensitivity and rapid diagnosis where X-rays weren't essentially readily available. So these findings demonstrate that POCUS's potential both in advanced hospitals and resource-limited environments. So yeah, there are three main advantages of POCUS over chest X-ray. One is safety, as POCUS is radiation-free, which is especially important for children who may need multiple follow-ups. Also, its speed and accessibility is notable as it can be performed at the bedside, which eliminates a lot of delays associated with transferring patients or waiting for radiologists, which is really important in the emergency medical setting. And it's especially useful in low resource settings where X-ray infrastructure may be unavailable and is less cost effective. So additionally, POCUS allows for repeatable real-time assessments, which can be really crucial for monitoring patient progress. So despite its promise, POCUS does have its limitations. So for example, it's highly operator dependent, which means that clinicians would require proper training. It also struggles to detect deep or central lung lesions. And lastly, it has issues with misinterpretation of ultrasound artifacts that can lead to false positives. So some studies found that less experienced clinicians achieved sensitivities as low as 89%, which underscores the importance of a standardized training for widespread adoption. So overall, the findings suggest that POCUS has the potential to become a first-line diagnostic tool for pediatric pneumonia and emergency departments. Its ability to deliver fast, accurate, and safe diagnoses can improve triage and treatment timelines, reduce radiation exposure in children, enhance diagnostic capabilities in low-resource environments, as well as aid in antibiotic stewardship, which helps avoid any unnecessary prescriptions. Moving forward, research should definitely focus more on standardized POCUS training protocols to improve operator consistency, developing hybrid diagnostic workflows where POCUS can serve as the primary tool and chest X-rays are reserved for more complex cases. And lastly, exploring the integration of AI-assisted POCUS interpretations, which could definitely reduce operator dependency and improve real-time diagnostic accuracy. So, just to conclude, POCUS is a highly sensitive and specific tool for diagnosing pediatric pneumonia, often matching or outperforming chest X-rays. Its safety, speed, and portability make it ideal for both advanced emergency departments and resource-limited clinics. And with further investment in training and technology, POCUS could reshape the future of pediatric respiratory diagnostics. So lastly, I'd like to thank my mentor, Dr. Mohammed Wasim, for his guidance throughout this project. He was truly supportive and encouraging throughout this process as well. And I'd also like to thank the Talaria Summer Institute for opening doors that I never thought possible as a high school student. And this program has allowed me to take my first real step into the world of research and has brought me closer to achieving my aspirations of becoming a physician dedicated to improving patient care. Thank you so much for listening. And these are my references.